Morning, Doc. Afternoon, Doc.
Hi, good afternoon, everyone.
Good afternoon, Doc.
Are we all in?
Sulod pa lang ang bat, Doc.
Maybe it's already 2 o'clock, no? Kanang, while waiting for the others, maybe we can start with a prayer. Can anybody lead the prayer before we start our lecture this afternoon? Oh, Cindy, you lead the prayer.
Everyone, good afternoon. So let us put ourselves in the holy presence of God, in the Father, Son, and the Holy Spirit. Amen. We pray for all things. A ray of your light penetrate the darkness of my understanding. Save from me the double darkness in which I have been born, and obscurity of sin and ignorance. Give me a keen understanding, a memory and ability to grasp the things correctly and fundamentally. Grant me the talent of being exact in my explanation and the ability to express myself with thoroughness and charm. Point out the beginning, direct the progress, and help me completion. I ask this through Christ the Lord. Amen.
Thank you very much, Cindy, for that prayer. So, good afternoon, everyone. So, welcome to the second, actually not the second, but this is the third module, no, for your lecture series in surgery. So, um, I am partnered together with Dr. Jason Sia. So for my lecture, it will be focusing more on the small intestine and the appendix, including intra-abdominal infections. No, while Dr. Sia will be handling the second part of the lecture, which will tackle more on the hepatobiliary tree, including the pancreas and the spleen as well. So I hope everyone is already in so that we can already start. Is it okay if kanang I maybe in the process of kanang kuan ba doing the lecture, okay, my connection might get lost. Is it okay if I just turn off my video?
Sure, Doc.
Okay, thank you. So for our schedule, we will follow the schedule for your block. So today I will be lecturing on the small bowel. It's quite a long topic, no, in the book, but I'll try to fit the important sections of the chapter today, no. If I might not be able to finish everything today, I can continue tomorrow and then tackle also about intra-abdominal infections. And then on a Friday, we will discuss the appendix, okay? So your SGD will start on October 4, and you have there the list of the facilitators that will be helping you out with your small group discussions. So your shifting examination for this is for all of the sections will be on November 5. That will be a Friday, 2 to 4 p.m. Okay, so please take note of the schedules. Okay, so most of the time, no, we are referred, patients are referred to us, no, surgeons, especially if we have patients that come in with problems in the abdomen. And one of the most common presentations of patients who come in for us would be abdominal distension, no? And this is usually secondary to problems um, relating to the luminal components of the abdomen. So when we say luminal components, these are the hollow organs, no? Either the stomach, the small intestine, and the colon. Okay. So for the course outline this afternoon, so we will have a brief review on the anatomy and physiology of the small intestine. then which will be followed by the important disease process related to surgery with regards to the small intestine. So we will discuss small bowel obstruction, ileus, small bowel neoplasms, intestinal fistulas, Meckel's diverticula, and short bowel syndrome. So there are some topics that I excluded, no? So and I am assigning them to you for your reading assignment. So you have your Crohn's disease, radiation enteritis, acquired diverticula, and mesenteric ischemia. They are just short portions of the chapter. So I am expecting for you to read on them because they will still be part of the coverage, for the examination. So let's go now to the review on the anatomy and physiology. Now, among all the organs in the abdomen, it is said that the small intestine is the most remarkable and complex organ, not only because it is the principal site of nutrient digestion and absorption, but it is also considered as the body's largest reservoir of immunologically active and hormone producing cells. So can you imagine a segment, no, in the abdomen measuring around 4 to 6 meters in length, no, containing cells that produce hormones in the body as well as immunologically active substances, no? So it is said that the small intestine, for a fact, is a tubular structure. So it extends, no, from the pylorus, which is the last portion of the stomach, down to the cecum, which is the beginning of the segment of the large intestine. So it has three main segments. So you have the first segment, which is the duodenum, which is marked or by color yellow there in the figure. So the duodenum comes from the pylorus or starts from the pylorus down to the ligament of Treitz. It is located in the retroperitoneum, immediately adjacent to the head and to the inferior border of the body of the pancreas. So it is followed by the jejunum and the ileum, no? So the jejunum and the ileum, these are portions of the small intestine that lie within the peritoneal cavity and are tethered. They are tethered to the retroperitoneum by a broad-based mesentery. Now, in terms of distinct anatomical demarcation, there is no such thing to demarcate the jejunum and the ileum, unlike the duodenum. However, if we talk about anatomy, it is said that the proximal 40% composes the jejunal part, while the distal 60% is composed of the ileum part. Um, the ileum, on the other hand, is demarcated from the cecum by what structure? Can anyone remember? Gio, what do you think is a structure that demarcates the cecum from the ileum? Hello?
Ileocecal valve, Doc.
Very good. It's the ICV or the ileocecal valve. So the small intestine contains the internal mucosal folds known as the plica circularis or the valvula conniventes. So later on, these structures can help us differentiate the colonic part or the large intestine part from the small intestine radiographically. So these valvula conniventes or the plicae circularis are folds found within the mucosa of the small intestine. So these folds are more prominent in the proximal intestine as compared to that of the distal small intestine. So they may, as I said, later on, we will be looking into radiographic pictures of of the abdomen and try to see how they differentiate, no? How these structures allow us to differentiate small intestine from the colon. Okay. So as I mentioned earlier, the small intestine is said to be the largest organ that secretes immunologic factors. No, it's because of the Peyer's patches, which are the aggregates of lymphoid follicles found within the small intestinal mucosa. So for the physiology, we all know for a fact that digestion and absorption, no, majority of it happens within the small intestine. So after food is digested in the stomach, no, approximately 8 to 9 liters of fluid enter the small intestine daily. So if you happen to take note of this picture, no, found in the slide, you have there the components of the fluid that is entering the small intestine daily. So you have the oral intake, the amount of saliva that is produced, as well as the gastric secretions produced daily. And not only that, in addition also there are other fluids, no, or secretions that contribute to the amount of the fluid located in the small intestine. So you have fluid coming from the bile, the pancreas, as well as even in the inherent mucosa, the small intestinal secretions can also reach into about 1,000 ml. So the good thing about the mucosa of the small intestine is that it contains a large amount or a vast amount of epithelium that is really characteristic for absorption. So later on, we will discuss after this slide. You have their carbohydrate, protein, and fat digestion, which is also present within the small intestine, as well as vitamin and mineral absorption. Okay. Can anyone remember where vitamin B12 is usually absorbed? John Clyde, do you know where the vitamin B12 is absorbed? What portion of the intestine?
Jejunum, Doc.
Hmm. Any other answer?
Ilium, Doc.
Ileum, Doc.
Part of the ileum.
It is absorbed in the ileum, no, particularly the terminal ileum, no. So segment, the most distal segment of the ileum. So that's why if there is any resection in the ileum, no, there might be nutritional problems that the patient could encounter post-operatively because of its main function wherein for B12 absorption. Okay. So next would be barrier and immune function. As I mentioned earlier, that since the small intestine contains a lot of lymphoid follicles, no, they are responsible for the production of immunoglobulin A, that is considered as one of the important defenses of our body, no, for infection. Um, this is known as the gut-associated lymphoid tissue function that is more or less domineering about contributing to about 70% of the body's immune cells. And then the next function that is also very important to mention is the endocrine function. So the small intestine expresses over 30 peptide hormone genes, no? And if you notice in your Schwartz, no, it's written there in a table. You have there table 28-2 that contains all of the hormones that are secreted within the small intestine. So you have the somatostatin, secretin, cholecystokinin, motilin, peptide double Y, glucagon-like peptide, and the neurotensin. Can anyone remember what's the function of cholecystokinin? How does it function, especially in the gallbladder? What's the
It's
action of cholecystokinin?
it stimulates gallbladder emptying, Doc.
Okay, so it stimulates the emptying of your gallbladder, thereby allowing bile no to go into the extrabiliary system. So that's one function of the small intestine, and that is to secrete no these hormones. Okay, so here this is just a summary of the absorption and digestion mechanism of the small intestine. So if you remember in your histology, we have studied this one, no, that the small intestine has how many layers? So it has 4 layers. Actually with 5, no, including the serosa. So you have the mucosa, the submucosa, and then you have the 2 layers of muscles. So you have your inner circular muscle and the outer longitudinal muscle, and the last layer, which is the serosa, which is the thinnest, no? So once chyme no is produced in the stomach, the chyme that is produced goes into the small intestine. So there would be mechanical and chemical digestion. So when we say mechanical digestion, this you remember the propulsion movement of the small intestine. So this allows mixing of the chyme with the other digestive enzymes that are produced inside the lumen of the small intestine, together with the chemical digestion secondary to the pancreatic juice that is added no into the intraluminal substances. So the absorption happens through the action of the villi no that are located within the lumen. So these villus projections no have microvilli that allow the food no or the nutrients to be absorbed no through the cells, and then these cells allow passage of the molecules from the GI tract to the blood or the lymph through the process of absorption. Okay, so the last function, which is intestinal adaptation, we will discuss it later on also in the last part. So among all the other organs in the body, the small intestine has the capacity to adapt in response to varying demands imposed by physiologic and pathologic conditions. So of relevance of the diseases that we will discuss here would be how does the small intestine adapt no, especially if there is massive bowel resection. So later we will tackle on the intestinal adaptation function of the small intestine when we discuss short bowel syndrome later on. Now, how does the small bowel or the small intestine differ from the colon, no, in terms of their function? So I have here a summary of a tabulation on how they differ, no. So we already know that the digestion happens greatly in the small bowel. So for the colon, it's more of absorption. Then you have the sodium nutrient transport, which happens in the small bowel, while potassium secretion occurs in majority within the colon, including bicarbonate secretion. Now, for the small bowel, since we know for a fact that from the previous slides that it is responsible for water absorption, although the colon still has that function, no, but majority of it is happening within the small bowel. Okay, so now let's go to the first surgical problem no, that we often encounter in the hospitals or in the clinics, which is small bowel obstruction. So mechanical small bowel obstruction is the most frequently encountered surgical disorder of the small intestine. Majority of which are attributed to post-operative adhesions. Now, although there is a wide range of etiologies for this condition, the obstructing lesion can be conceptualized according to the anatomical relationship of the intestinal wall. So we can divide small bowel mechanical obstruction into different types. First would be the intraluminal type, which is one example of this one would be the presence of foreign bodies, gallstones, or meconium. So anything that blocks the lumen of the bowel can cause bowel obstruction. So that is secondary to an intraluminal cause. The next type would be an intramural cause, which are secondary to um, tumors, or um, diseases related to the muscles, such or the affecting the mucosa, such as the Crohn's disease, inflammatory bowel diseases, or that may cause strictures later on. And then we have the last one, which is the extrinsic type of obstruction, which is secondary to extraluminal causes such as adhesions and carcinomatosis. So we have here in the slide examples of these causes. So you have there herniation and adhesions, which are extrinsic type of causes for mechanical bowel obstruction. So volvulus can also be a cause of extrinsic mechanical bowel obstruction because as you can see, there is twisting of the bowel upon itself. So it's usually extraluminal. And then we have intussusception, which can be an intraluminal cause of obstruction, wherein there is telescoping of the bowels into the proximal portion of the bowel. So these are just some of the examples of mechanical bowel obstruction. But as I mentioned earlier, among all causes, it is said that the intra-abdominal adhesions related to prior surgery that account for 75% of cases of small bowel obstruction. So here, this is a table found in your book, So it listed the most common causes of small bowel obstruction, and you notice there, if you notice, adhesion goes as the number one cause, for obstruction. Now, um, if we look at statistics, in the states, according to what was written in the book, there is about, for example, if we have 300,000 patients estimated to undergo surgery, there are almost 75% of these patients, this number will still have second surgeries secondary to small bowel obstruction because of the adhesions that were derived from the first surgery. So there are also other less prevalent etiologies for small bowel obstruction. So I mentioned them earlier. So you have your hernia, malignant bowel obstruction, and Crohn's disease. There are also cancer-related small bowel obstruction, usually secondary to invasion of and of extrinsic compression, and other causes are listed there. So you also have volvulus, diverticulitis, congenital abnormalities, which are common among children. Okay. So, what are the classic signs and symptoms of a patient coming in with small bowel obstruction? Most of the time, they will come in with colicky abdominal pain, nausea and vomiting, emesis, distension, abdominal distension, and obstipation. Now, the classic symptoms of small bowel obstruction is usually secondary to the pathophysiology of the disease itself. So, we know for a fact that once obstruction happens, no, there would be fluid and gas accumulation within the small intestine. So it's just like kanang water pipe, di ba? So when the water pipe is kanang barado, no, or it is obstructed, what happens? Water will try to find a way for it to overcome the obstruction. So it's similar to that, no, sa small bowel. So gas and fluid will accumulate, no. Thus, since the intestine will try, no, to overcome the obstruction, that will thereby the patients will manifest with colicky abdominal pain, nausea and vomiting as well. And then sometimes, no, if there is complete bowel obstruction, there will be obstipation or absence of flatus, no, or the patient will not be able to pass out flatus. Vomiting is a more prominent symptom with proximal obstructions than distal obstruction. So usually, what's the character of vomiting for proximal obstructions? What do you think will be the character of the vomiting? Andy.
Bile stain, Doc. Proximal, yeah, bile stain.
Yes, very good. No, because no, it is, remember where the ampulla of Vater is located, di ba? It is located near in the second portion of the duodenum. So if the vomitus is bile stain, no, most probably you are dealing with a more proximal obstruction in the small bowel. While if, for example, the vomitus is more feculent uh, or fecal in nature, it is suggestive of a more established distal obstruction. Okay, so there is such a thing, no, known as strangulated bowel obstruction. So in strangulated bowel obstruction, the patient will often come in with pain, no, in the abdomen, which is disproportionate to the degree of your abdominal findings. So for example, the abdomen may be soft, but the patient really complains of very severe pain, 9/10, no? If you allow him to quantify it, this could be possibly suggestive of intestinal ischemia. Now, the intestinal ischemia is secondary to a very high intramural pressure that causes intestinal microvascular impairment in the intestinal microvascular perfusion. So thereby causing the bowels to be what? Necrotic. So if you look in this picture, you can see areas of starting to have necrosis. So you have the normal bowel will usually appear as pinkish, no? But here you could have segments already that are necrotic, indicated by bluish discoloration in the bowel wall. So this is a classic picture of a strangulated obstruction. So aside from pain disproportionate to the degree of abdominal findings, the patient will have tachycardia, abdominal tenderness, fever, leukocytosis, and acidosis. So what are the common clinical presentations of small bowel obstruction? Okay. So typically, the presentation of the patients would be based on three factors. First is the severity of the obstruction, whether it is partial or complete. Next would be the anatomic site of obstruction, whether it is located proximal or distal. So as we have mentioned earlier, so if it is bile stain, the vomitus is bile stain, then we are thinking of a more proximal type of obstruction. And the last factor would be the elapsed time between the onset and the presentation, which is very, very important because the earlier that you can detect small bowel obstruction, the more chances for you to be able to reverse the obstruction through a non-operative measure, no? As compared if you have seen the patient quite a very long time, no? So there would be a chance for possible strangulation of the bowels because of the prolonged time of obstruction. Laboratory findings usually reflect intravascular volume depletion, hemoconcentration, electrolyte abnormalities such as hypokalemic, hypochloremic metabolic alkalosis, and sometimes mild leukocytosis is common. No? So let us first define, no, what are the types of small bowel obstruction depending on the severity and the anatomic site. So when we say complete obstruction, it means that the entire bowel lumen is completely obstructed. So the patient has no passage of stool or air. No, when we say it's partial obstruction, meaning that the bowel lumen is narrowed. So there is still space, no, for gas to pass through or fluid to pass through. So there is still distal passage of bowel contents. Well, we also have the open loop obstruction. So this occurs when there is proximal decompression, probably via emesis or nasogastric tube insertion. And then we have the closed loop obstruction, which occurs when there are 2 points of obstructing elements, no, found within the small intestine, causing both proximal and distal bowel obstruction. And lastly, strangulation. This involves compromise of the blood flow, causing blood necrosis, bowel necrosis rather. So how do we do the diagnosis for small bowel obstruction? Now, according to Schwartz, the diagnostic evaluation should be goal-oriented. So there are four goals that are mentioned. So first, you have to distinguish mechanical obstruction from ileus. Second is you have to determine the etiology of the obstruction. Third is you have to discriminate or determine, no, rather, partial obstruction from complete obstruction. And lastly is to discriminate simple obstruction from strangulating obstruction. Now, you can be able to get important information, no, if you do the patient's history properly and you know the questions to ask. So, for example, if you have a patient whom you suspect to have obstruction, no? Patient came in with abdominal distension, not able to pass out flatus or stool, no? And the patient is already vomiting with several episodes of vomiting. So you are thinking of a possible obstruction. So what are the important information that you should obtain on history? So first and foremost is what? Prior operation. So remember, what is the most common cause of obstruction? Most common cause of intestinal
Adhesion, Doc.
obstruction.
Adhesion.
Yes. So adhesion. So remember that adhesions are formed, no, especially if there is a history of prior operation. So you really have to ask the patient, ma'am, sir, did you have any previous operations that were done? I mean, this will be even if the patient will deny this, no, but if you look at the abdomen and there are obvious abdominal scars, then that will already tell you that this patient had prior operation. So this is very important. So to rule out obstruction, probably secondary to intestinal adhesions. Next is the presence of abdominal disorders. No, abdominal disorders such as unsa man? Such as what? Lavinia, such as what? Abdominal disorders such as unsa man?
Inflammatory bowel disease.
Be specific. Stomach and bowel disease. What?
Crohn's,
Type?
Doc.
Okay, so Crohn's disease, inflammatory bowel disease, tuberculous enteritis, nor TB, extrapulmonary TB. So you have to ask them because this may cause obstruction. As I said earlier, for Crohn's disease, it may cause strictures intraluminally. So they may have predisposition to have intestinal obstructions later on. And then lastly, you have to search for hernias, no? So hernias are very, very common, no? So if, for example, if you have a patient virgin abdomen, when we say virgin abdomen, wala jud sila nakaagi og surgery, meaning no scars, no previous intervention done. So if you are thinking of an obstruction, it can be probably secondary to a tumor, no? But you have to quantify the age or to consider the age of the patient. So man, tigulang ni siya. If the patient is old, the chances for cancer is very high. If the patient is young, the patient is least likely to have a neoplastic process. So then you can search for possible hernias because sometimes hernias in the inguinal area that are strangulated or incarcerated can cause also intestinal obstruction. Okay. So what are the important diagnostic tools that can help us in establishing the diagnosis of small bowel obstruction? So one of the important tools that we use in the hospital setting is radiographic examination. So abdominal series x-ray that is composed of an upright x-ray of the abdomen and supine x-ray of the abdomen as well as an upright chest x-ray can help us in determining whether there is possible obstruction in the patient. Okay. So we have here, this is a supine picture of the abdomen radiograph. So you can see there very clearly that the picture is usually infradiaphragmatic down to the pelvic area. So I'll try to annotate so that okay. So if you can see here, sorry. Ano ba yan? Paano i-annotate? Okay. So you can see here, very enlarged small intestine, So that is encompassing majority of the upper portion of the abdomen. So why did I say that this is small intestine, not colon? Look at the character of the bowel. You can see what do you call this one? I can trace some of them here and see it very clearly. So these are the folds that I have mentioned earlier. So these are the, what do you call this? Mucosal
Valvulae
folds.
conniventes.
Yes, so these are the valvulae conniventes or the plicae circularis. So they appear as such on X-ray, especially if the bowels are dilated. So remember that gas appears to be black on X-ray. So you can see it very clearly that there is intraluminal gas within the X-ray. Okay, and then you can see the folds. So that's why I say this is the small bowel that is dilated. Okay. Next would be ang annotation. Sorry na pagyapon, but don't mind na lang sa katong annotation nga nasuwat kay na-appeal siya sa slide. How do I remove this one? Matanggal pa ni?
Madelete na nimo sa kilid, Doc.
Here? Unsa man akong ikuan?
Dapit sa annotations nga part.
Okay, delete. Clear all my drawings. Okay, thank you, Doctor. Thank you. So, Next would be an upright X-ray of the abdomen. So you can see it very clear there, no? So you have the stomach with the gastric bubble, and then you have the enlarged, no, or dilated small bowel, as I mentioned earlier, with very clear valvulae conniventes. Now, on the upright position, the finding most specific for bowel obstruction would be the presence of air fluid levels on upright film. So here, the air fluid levels, can you see the air fluid levels here?
Yes, Doc.
Be, asa man dahil. Sige, I'll point ha. So this one is an air fluid level. This one is another air fluid level. This one is another fluid level, and this one is another one. Now, why do we expect air fluid levels when the patient is upright? Can anyone answer that? On X-ray, why do you think that there would be air fluid levels?
Because air rises up, Doc, and the fluid sinks below sa iyaha.
Okay. Very good. So by gravity, no, ang fluid will usually go down, no, while air goes up. So if, di ba, remember when there is obstruction, what happens to the fluid content intraluminally? There will be an increase in the amount of intraluminal contents or fluid. So if there is more, if you notice in this X-ray, there is a step ladder approach, no, meaning there are many areas of air fluid level, then this patient most probably has an obstruction somewhere in the small bowel. Okay, so another view that is very important is the chest X-ray upright. Why is it very important? Because it allows us to check, no, for presence of possible pneumoperitoneum. And pneumoperitoneum is usually seen here, no? So it is usually visualized as presence of air located, no, underneath the right diaphragm. So presence of pneumoperitoneum can indicate what problem in the abdomen. If you have obstruction, what is the possible indicate, or what does the presence of free air in the abdomen tell you if you are thinking of obstruction?
Perforation, Doc.
Yes, very good. So there is possibility of a perforation somewhere in the small intestine or within the hollow organ. So free air is already an indication that there might be a need to do surgical exploration sa patient, no, since it indicates perforation of the hollow viscous, most particularly the small intestine. So in the X-ray findings, no, it is very important for you to establish 3 specific findings for small bowel obstruction. So first is the dilated loops of small bowel. So when you measure the lumen of the small bowel based on the radiographic finding. If it is greater than 3 centimeter, then that is considered as dilated, no? Second important finding, which is the presence of air fluid levels. And lastly would be the paucity of gas within the colon. So remember in this picture, first picture that I've shown you, there must be paucity of air within the pelvic area or within the colon or the rectum going to the pelvic area. So if you can see here on this X-ray, can you see gas in the rectum? Yes or no?
Yes, Doc.
Yeah. Yes, no? You can see gas, no, as seen there, no, in the middle within. So the whitish area, that is the bladder. If you can see on top, there are areas that are hypolucent, no, meaning black siya, containing air. So that area is the rectum. So there is still presence of air within the distal colorectal portion. So in this patient, the bowels may be dilated, but it doesn't tell you that it is obstructed. Okay. So in order for you to establish obstruction, the three findings should be present. So this is the triad that we need to see on the abdominal radiographs. So the advantage of abdominal radiographs, number one, it is readily available and cost-effective. Barato ra siya, no? Yeah. I think karon even the district hospital, they have a radios kanang department, no, or an X-ray, which is very very basic. However, in terms of sensitivity and specificity, the X-ray, abdominal X-rays, may be sensitive in detecting small bowel obstruction up to 70 to 80%, but it is less specific because there are other problems in the intestine, such as ileus and colonic obstruction, that can have the same findings as observed in the small bowel obstruction. So sometimes we may need to do other studies for that, to confirm whether the obstruction is secondary to a small bowel lesion or small bowel problem rather than a colonic one. So here, this is an X-ray. You can see very clearly that the small intestine, no, is dilated and has formed a loop, no. So you can see it very clearly there. However, you can also see at the background, no, pockets filled with air. So this area located at the back is representative of the colon. So in up close, this is how usually the plicae circularis would look like on up close. So they would form like a stack of coins, no, on X-ray. And how do you differ that from the colon? So here in this picture, no, you can see clearly the pockets of air that are formed in the colon. So what do you think? What do you call the equivalent of the plicae circularis or valvulae conniventes in the colon?
Frustrations, Doc.
Very good. So these are the haustrations. So you can see very clearly the pockets of air located in the colon as represented by the haustrations, no, found within the colonic mucosa. So this is how you differentiate small bowel from large bowel on X-ray. Okay. So another important imaging study that we can use to determine small bowel obstruction is computed tomography scanning or the CT scan. It is 80 to 90% sensitive and it is more specific as compared to that of an X-ray. Because it can give us a lot of information such as what could be the probable cause of the obstruction and where the location is. Usually we do not do CT scan that is plain film. No, we usually do it with oral contrast, no, to make sure that the intraluminal contents as well as the other structures are identified. And the pathognomonic findings for CT scan are as follows. So if there is really obstruction, there would be a transition zone, no, that you see in the small intestine, with the dilatation of the bowel proximally and the compression or collapse of the distal bowel. And there would be no contrast going beyond the transition zone. So strangulation at times can also be seen, no, based on the CT scan findings, because there would be thickening of the bowel walls, presence of pneumatosis intestinalis or presence of air within the intestinal wall, as well as poor uptake of IV contrast into the affected bowel. So for this is a coronal view of a CT scan, no, of the abdomen of a patient. So you can see there the whitish portion, no, is the contrast, no. So it helps us to determine whether how far the obstruction is, and the contrast also delineates whether there is presence of mass or not, or none, no. So in this particular arrow, if you can see there, no, there is narrowing of the small intestine towards this portion, and there is no passage of dye, no, towards the distal portion of the small bowel. So this is considered as the transition zone. So this is indicative of a possible small bowel obstruction. Okay. So the other picture, no, will show to you a very clear view of the small intestine, which is dilated, no, with possible obstruction as well, because there is no flow of the dye towards the entirety of the intestine. So these are the findings of the CT scan that is associated with bowel ischemia. So as I mentioned earlier, there might be thickening of the bowel wall with the presence of pneumatosis intestinalis. For the mesentery, there would be engorgement and edema. And then there might be also free fluid present in patients who are presenting with ascites, as well as the presence of portal mesenteric venous gases. So if you notice for the CT scan findings, they are more specific, no, in terms of determining bowel obstruction as compared to that of just a plain radiograph. So this is a cross-sectional view. Okay, so if you notice, there is edema of the bowel. Okay, and we have small pockets of air found within the bowel wall. What do you call this one? Okay, so this is the typical picture of pneumatosis intestinalis. So this finding is very indicative of a possible bowel ischemia. So once you see this, most probably the patient should be brought to the OR for emergency surgery. Okay. Now, you might want to ask, Doc, can we perform endoscopy so that we can visualize what are the structures that are obstructed and what is the cause of the obstruction? Now, endoscopy is contraindicated for cases of complete small bowel obstruction. So when we say complete small bowel obstruction, these are the patients with abdominal distension, those coming in with no passage of flatus and stool, no. Remember that once obstruction happens, no, there will be dilatation of the bowels. And what happens to the walls of the bowels once it is dilated? What happens if there is too much dilatation? What happens to the bowel wall?
It thins out like a balloon, Doc.
Okay, so it thins out. Now, if you introduce a scope, no, intraluminally, and there might be possibility of movement of the scope, there is also a chance for what?
Perforation, Doc.
Very good, perforation. So there is a high chance for perforation if we do endoscopy, especially for patients coming in with complete small bowel obstruction. So instead of doing more, helping the patient out, you're doing more harm. However, for cases of partial small bowel obstruction wherein there is still passage of flatus, there is still a small space, no, where there could be gas movement and fluid movement with less bowel dilatation, then we can do endoscopy for those patients, no. But in general, for complete small bowel obstruction, this is a no, no. Endoscopy is not allowed. Okay. Now let's go to the therapy. How do we manage patients who come in, doc, with obstruction? Now, earlier we have mentioned the different types of obstruction. So it is very important at your level, no, that when you see a particular patient in the ER or in the OPD, that you'll be able to distinguish whether it is a complete type or a partial type of small bowel obstruction. Now, for the non-operative management, this is only applicable for those having partial small bowel obstruction, those who have obstruction occurring in the early post-operative period. So later on, we will discuss about ileus, intestinal obstruction secondary to Crohn's disease, and those with carcinomatosis. Now, you have to make sure that for non-operative management, you have to qualify the patients, that these patients should have no clinical deterioration, no, and should show some evidence of improvement over the first 12 to 24 hours when you do your non-operative management. So when we say non-operative management, this would include fluid resuscitation, bowel rest, gastrointestinal decompression, no. So after you have given this to your patient, if they present, no, with some degree of improvement, no, during the first 12 to 24 hours, then you can say that we might that non-operative management can be helpful for these particular patients. Now, in terms of, in general, for bowel obstruction, one important treatment that we can give, an initial assessment would be fluid resuscitation. Remember that small bowel obstruction is associated with marked depletion of your intravascular volume due to decreased oral intake. The patient is vomiting. There would be sequestration of fluid within the intraluminal component of the bowel. So that's why it's very integral. So remember that for fluid resuscitation, isotonic fluid is advisable. So what are the types of isotonic fluid available in the hospitals? Do you know some?
Doc.
Yes,
Brain
Auntie.
and lactic
And
bringers, Doc.
NSS.
Lactated ringer solution, you have your plain NSS, no? So there are some new preparations already almost similar, no, to the plasma. So we have plasma light. So we can give this intravenously, and we should be able to compute the fluid requirements properly. Then important also, how do we determine if we have properly hydrated the patient? So we need to place an indwelling urinary Foley catheter in order to monitor the urine output. By the way, what's the normal urine output that you expect for an adult? What should be the normal urine output?
30 per hour, Doc.
Pila?
30 ml per hour.
Is it the same for all patients? Like for example, kung ako 110 kilograms akong patient, normal ba paghapon na ang 30? So how do you compute for the normal, the expected urine output? What should be the target? You should have a target. Okay, for example, ang 30 cc per hour, is it the same if I have a 50 kilogram patient?
No, Doc. It should be based on the kilos of the patient.
So what's the target?
1 to 2
Is it
cc per kilogram per hour.
1 to 2 cc? Are we talking about a pediatric patient? We are talking about an adult patient. So what's the expected? Anyone? La, basic ni uy. Andy, Komya, pila man?
Ikaw pa ko daw po.
Hello?
Point 0.5 to 1.5 cc per kilogram per hour, Doc.
Very good. So 0.5, no? 0.5, at least 0.5 cc per kilogram per hour. So 0.5 to 1, no? For children, it's usually 1 to 2 cc per kilogram per hour. So you have to compute your target urine output. So anything less than that would mean that your patient would be probably dehydrated. Also, you have to look at the clinical signs and symptoms of the patient, diba? Of kanang dehydration. So, unsa may mga clinical signs and symptoms of a dehydrated patient? Michi Ong, what's the clinical presentation?
Dry skin, Doc. Flush skin. Pwede po siya.
Unsa pa?
No
Sa
capillary refill time.
What else?
Sunken eyes.
Dry ang... sige.
Sige, unsa pa, Mark? Mark Lim, what are the other signs and symptoms?
Kondo.
Or skin turgor.
First, for skin turgor, basi mo answer niya mo o ka ng depressed fontanelle sa bata to siya. So this is an adult. So if the patient has dry lips and tongue, no? Kanang ang patient kay thirsty siya, no? Kung tanaw ninyo siya, mura siyang uga, no? So these are the signs and symptoms of dehydration. So then you also look at the urine output, no? As well. So if there is signs and symptoms, then you have to replace the fluid requirement of the the patient's fluid loss. So lahi ang fluid requirement in addition pag yun sa iyahang fluid replacement. Sometimes you might need to place a central venous pressure monitoring catheter, especially for critically ill patients like those with cardiac disease or those coming in for severe dehydration. No, there are times also that we can place Swan's Gans catheter, no, but especially for very morbid patients in order to check really directly whether there is dehydration or not. Now, the next aspect of your non-operative management would be to place a NGT tube, no, for gastrointestinal decompression. So, remember that your fluid, no, accumulates intraluminally, and this causes distension as well as the air, no, present inside. So, your NGT is very important to decompress the stomach, and effective gastric decompression decreases the incidence of nausea, distension, and the risk of vomiting and aspiration. So there are longer nasoenteric tubes wherein the tip can be located into the jejunum or ileum, but we don't usually use that today. We use the conventional NGT tube, if you're familiar with that. No, so when done effectively, it causes the risk of aspiration for the patients, no? And of course, the distension secondary to the presence of intraluminal air, no, will also be relieved. Okay. Then after this one, you can do when you think that the patient has responded to the conservative management, you must have the goals of resolving the electrolyte imbalance as well as the acidosis that the patient has. Now, for patients who have obstruction, it is also very necessary to give antibiotics, since we know for a fact that placing the patient on NPO or nothing per orem can cause already bacterial translocation. So you can start with broad spectrum antibiotics as well as part of the non-operative treatment. Now, the next question that you will ask is usually, Doc, when do we say that the patient should be operated immediately? Okay. So, for cases of complete small bowel obstruction, so again, For complete small bowel obstruction, these are the patients that come in with abdominal distension, those that come in with abdominal pain with no evidence of passage of flatus and stools. So the standard therapy should be surgery. There's a saying in surgery, no, nga, that the sun should never rise and set on a complete bowel obstruction, because if you don't do the surgery expeditiously, there is a chance for poorer outcomes for among these patients. It is because we want to minimize the risk for bowel strangulation. Remember, as I said earlier, that the outcomes of the patient will depend, no, aside from the anatomical location, the type of obstruction, whether it is partial or complete. Another factor important would be the time period, no? So from when the obstruction started as to when your intervention happened. So you have to operate before the onset of irreversible ischemia happens. So what are the cases of bowel obstruction wherein you have to do emergent operative management? So these are the patients coming in with peritonitis. So when we have peritonitis, what are the expected abdominal findings that you need to see among patients when you do your PE?
Rebound tenderness, Doc.
Rebound tenderness, kulang siya, gyro. So usually they will come in with acute abdomen. So there is direct and rebound tenderness on all quadrants, no? So these indicate that the patient has peritonitis. Closed loop obstructions, meaning on X-ray you see that there are 2 points of two areas wherein there is obstruction, proximal and distal obstruction. So strangulation. So patient comes in with abdominal pain, disproportionate to the abdominal findings with leukocytosis, fever, no, and evidence of abdominal pain. So these are the cases wherein you have to do immediate intervention, no, for the patient. So I'm sorry for the blurred picture, no, but this is just an example of how the intra of findings usually will happen. So if you can see there, no, this is a case of a small bowel obstruction. There is a loop of intestine, no, and in this area, this is the point of obstruction. It is unfortunately attached to a adhesion, no, in between the two loops of bowel. So through in surgery, if the bowels are not compromised, no, we all we have to do is just to release these adhesions, no, take these adhesions out and free the bowel, ensuring that there is continuity of the flow of the bowel contents. Okay. So this is just a summary or an algorithm of how patients with obstruction, small bowel obstruction are approached. So if a patient comes in with possible suspicion of small bowel obstruction, okay, so you have to check, no, whether the patients have signs and symptoms of strangulation and intestinal ischemia. If there is, then you have to prepare the patient, no, for emergency surgery, optimize the patient, no. If there is no signs and symptoms of strangulation and possible ischemia, then you have to qualify whether the patient has partial bowel obstruction or complete bowel obstruction. Okay. So either way, if they have no partial bowel obstruction, you can place a patient on NPO, give proper fluid resuscitation, and do NGT placement or gastric decompression. And you can also start giving antibiotics and do serial abdominal examination. If the patient happens to improve, no, during the first 12 to 24 hours, you can do conservative management, no, and until the patient improves and you can return the diet, no, you can let the patient eat, no, without any signs and symptoms of obstruction. But if during your observation process the patient presents with signs and symptoms of intestinal ischemia, then you have to bring the patient to the operating room for exploration. For cases of complete bowel obstruction, so we still follow the same algorithm. So you place a patient on NPO, do fluid resuscitation, and do nasogastric tube decompression. Antibiotics as well should be given. If, for example, there are signs and symptoms of intestinal ischemia, then you can bring the patient to the OR. However, if there are none, then you can choose to conservatize for the first 24 hours. However, if you think that there is no improvement within the management that you are giving, then you are warranted to bring the patient to the operating room for exploration. Okay, so operative management can be to the form of adhesiolysis if the cause of obstruction is secondary to intra-abdominal adhesions. If it is secondary to neoplasms or tumors for at that, especially if you have an old patient, then you can do tumor resection. If it is secondary to a hernia, then you can reduce the hernia and the bowel contents, no, and close the hernial sac. Okay. If during the operation, intraoperatively, you find areas of necrotic sections of bowel, then there is no thing such as to conservatize. No, you really have to do bowel resection, especially of the non-viable portions. Now, you might ask, Doc, how will we know if the bowel is still viable or not? Okay, so there are clinical findings that you should have, no? So that would suggest bowel viability. So first is the color, very obvious. So katong gipakita nako ganina nga nangitom na siya ang bowel, no? Then nag-blue-blue na siya. Obviously, that is not viable already. So you can resect those areas. So a good healthy small intestinal bowel or small bowel would appear to be pinkish, no, or reddish in color. Then there will be presence of peristalsis. So you can observe this. You can dip or you can place warm water naman, warm NSS. Basin mo, ingon na po nga water ang ibutang ha. Warm plain saline solution, no, into the abdominal cavity, and you can see the movement, no, these propulsions or what we know as peristalsis. If the center that you were in or the hospital we're in, you do the operation is medyo kanang kuan siya, medyo advanced, no, we can do Doppler probe. The use of Dopplers can be done to check the flow of the blood to the bowel. But in the absence of a Doppler, you can observe for marginal arterial pulsations. Diba? Remember, within the mesentery, you can see the artery or the arcades, no, that supply the bowel in its entirety. So you can observe for the pulsations, no, if they are present. Sometimes if you cannot see it, you can feel for it. And then the last exam that you can do would be a Woods test, wherein you can use a fluorescein IV dye, inject it through the vessels, no, or the mesentery, and then under the UV light, you can visualize the dye to be present within the bowel wall. So if that area has vascular compromise, the dye cannot be what we call this, delivered into the bowel wall. So absence of dye within the bowel wall. Hello, am I still here? Okay. Absence of dye within the bowel wall, no, can indicate that the bowel is already necrotic or there is vascular compromise. Now, how do we differentiate ileus or intestinal pseudo obstruction from that of small bowel obstruction? So, I know you have heard no kanang mga patients nga gipang operahan. But for surgeons, di mo matingala, you aren't you kanang what you call this, asking yourself ba, why is it nga for surgeons very important man kaayo nga they ask the question sa patient, nakautot na ka, ma'am, nakautot na ka, nakalibang na ka, or have you passed out flatus? Were you able to pass out stools? No, it's very important for us. No, mas importante na siya sa amoa because remember that if the patient has who underwent major surgical surgery in the abdomen, like for example surgical resection, no, so absence of flatus or absence of passage of stools can lead us to think that maybe there might be something wrong with my surgery or why the patient is obstructed. Now, there is a phenomenon known as ileus. No, then this is common, especially for patients who undergo abdominal surgeries. No, especially those who have bowel manipulation. This is caused by impaired intestinal motility and characterized by signs and symptoms of intestinal obstruction in the absence of mechanical obstruction. So when we say mechanical obstruction, these are the causes that I have mentioned earlier, either through adhesions, presence of neoplasms, no, or strictures. So the good thing with ileus is that it is reversible with time. Or as for those that are caused by the previous ones that I have mentioned, there are times that the cause may not be reversible. So um as long as the inciting factor is corrected, ileus can be reversed. There are some people also, especially for the older patients or those who are chronically bedridden, who happen to have chronic intestinal pseudo obstruction known as the Algivis syndrome. No? So it is a spectrum of specific disorder associated with irreversible intestinal dysmotility. And among any other post-operative sequelae, no, ileus is considered as a major cause of morbidity in hospitalized patients. For example, if you have a patient with who underwent appendectomy, no, if kanang without considering nga ang patient nag-ileus, usually a day or two, the patient can be discharged. But if the patient unfortunately happens to have ileus, no, it can cause prolonged hospital stay. So prolonged hospital stay can what? Increase the cost of hospitalization as well as can cause what? Nosocomial infections in the hospital. So that's why it's a cause of morbidity among hospitalized patients. So daghan na dato nga hospital tungod sa ileus kay ang patient dili man makauli right away. So that's why as surgeons, no, we really try our best to avoid these post-operative sequelae so that our patients can go home early. Now, why does ileus happen? No. So remember that when a person undergoes surgery or undergoes general anesthesia at that, there is a normal course for the return of normal motility. So usually it's the gastric and the colonic motility that returns to normal by 48 hours and 2 to 5 days. So we usually expect the small intestinal motility to return to normal after 24 hours post-laparotomy or post-exploratory laparotomy. So, however, there are times wherein there is, instead of 24 hours post-laparotomy, this is prolonged, no? The gastrointestinal tract is transiently impaired. So the causes for that would be, the cause for those mechanism would be surgical stress-induced sympathetic reflexes. Sometimes also, if there is too much inflammatory process no in the abdomen, meaning for example the patient came in with very generalized peritonitis wherein you opened up the patient, there is pus everywhere, no, there is purulent discharge everywhere, for example in a case of ruptured appendicitis. So this inflammatory response mediator release in sepsis can also cause ileus post-operatively. Aside from that, anesthesia, no, general anesthesia or analgesic side effects can cause ileus as well. So this can inhibit intestinal motility. Okay, that's why very important, no, for patients post-op, we usually once the patient can walk already, usually we recommend them to mobilize, no, within the first 24 hours if they can, no, in order to enhance motility of the intestines, both colon and the small intestine. Um, they say that functional evidence of coordinated GI motility through the form of passage of stools and flatus is a more useful indicator of bowel motility. Later on, when you go to internship, no, and you are monitoring a post-op patient, sometimes the resident will tell you, okay, you listen to the bowel sounds, no, but you know, bowel sounds maybe is sometimes relative because there are times nga I can hear something but the other person cannot hear, no, the bowel sounds, no. So it's kind of relative because it depends on how often how sensitive your ears are to listening the bowel sounds. But you know, when you ask the patient, have you already passed out stools or have you already passed out flatus, it's more kanang koan ba, it's a more useful indicator rather than listening to the bowel sounds, no, on auscultation. So patients with ileus should also be worked up for possible electrolyte imbalance or presence of intra-abdominal abscesses because, as I mentioned, presence of such can cause delay in the resolution. So what do you think would be the most common electrolyte imbalance post-operatively that can cause ileus? Gawin yung tanaw.
Is it hypokalemia, Doc?
Yes, hypokalemia, no? If you notice, hypokalemic patients, di ba, aside from very poor muscular reflexes and movement, so remember that the small intestine also have muscular components. So it can cause, no, delay in the motility of the bowel, no, because of the potassium loss. So usually those patients who have hypokalemia post-op, they will manifest with ileus. However, as I said, this is reversible. So if you treat the hypokalemia, so you give potassium, no, to the IV fluid, the electrolyte imbalance is corrected and the resolution of ileus also happens. So the management for ileus actually is to, number one, you try to limit oral intake and you correct the underlying inciting factor. So if there is electrolyte imbalance, then you try to correct the hypokalemia. If there is intra-abdominal abscess, then you try to correct the abscess by drainage or by treating it with the correct antibiotics. Before we go to the small bowel neoplasms, I'd just like to mention to you that partly for intestinal ileus, no, they say that some of the measures to reduce post-operative ileus can be helpful, no. So as I mentioned earlier, ileus always happens in cases wherein there is bowel manipulation intraoperatively. So intraoperatively, we try, no, as surgeons, we try to minimize the handling of the bowel as much as possible. If we can do it laparoscopically, the procedure, then it would so much the better. Later on, if as you go along the topics in surgery, no, one advantage of doing a minimally invasive surgery or procedure is the decreased incidence of ileus, no, as compared to that of the open type of procedures. Then we also restrict intraoperative fluid administration, no, especially for cases wherein the patient is stable, in order to avoid bowel edema at that. So for the post-operative measures, no, enteral feeding administrated earlier can also cause the return of normal motility of the small intestine earlier as well. So sham feeding, if you know, if you have heard of the term sham feeding, SHAM feeding, no, try to research on it. So for patients undergoing major surgery, we do sham feeding. Some of them, they are given chewing gum, no, or they are allowed to suck on candies or koan or ice cubes, no, prior to initiating enteral feeding or oral feeding in order to stimulate peristalsis, no, to happen. And then, as I said, anesthesia can also be a factor. So if we can go away with general anesthesia and do epidural anesthesia, so much the better. Then, then correct the electrolyte abnormalities. And of course, you consider the use of mu opioid antagonists. So remember, there are analgesic types that can also cause a delay in the motility of the stomach or stomach as well, or the small intestine rather. Thus, sometimes we are advised to use the mu opioid antagonist for analgesia. Okay, so let's try to go to the small bowel neoplasm. So, importantly, for small bowel neoplasms, these are usually common for older groups of patient population. So among the neoplasms that we encounter, it's the adenomas that is considered as the most common benign neoplasm of the small intestine. So there are also other benign tumors that include the fibromas, lipomas, hemangiomas, lymphangioma, and the neurofibromas that we encounter. However, in general, for small bowel neoplasms, the prevalence of these tumors is very small at around 0.2 to 0.2 to 0.3%. So very, very small. So that's why with the small incidence rate, no, this usually suggests that small bowel neoplasms majority are asymptomatic, no. If for example patients come in with symptoms, usually dako na gyud na siya nga tumor sa small bowel, no, but at times, no, they are usually seen incidental findings on endoscopy, or sometimes they are just seen as findings in autopsy. Now, the reason, there is mechanism done by the small intestine as to why, no, within the portions of the GIT, among all the segments, no, we have the stomach, small intestine, the colon, the rectum. Why is it that the small bowel has a low incidence of cancer or tumors, no? So they postulated it that it is because of the following physiologic functions that happen within the small bowel. So there is a dilution of the carcinogen in the liquid chyme. Remember that the chyme that is coming from the stomach is greatly acidic, no? So once it goes into the small intestine, if there are carcinogens manggaling, nalanay na siya sa acidity sa chyme. And also there is rapid transit of the contents through the small bowel, no? So if you notice, ang transit time sa small bowel from the stomach to the small bowel to the colon is really, really fast. Okay, so that could be one cause of that's why there is a low incidence of small bowel tumors. Third is that there is a low concentration of bacteria in the small intestine. So since there is a low concentration of bacteria, there is also a low concentration of carcinogenic products secreted by bacterial metabolism. So that's one cause. And then the fourth cause would be mucosal protection. Remember that the Peyer's patches secrete a lot of IgA, no? Secretory IgA in your hydrolysis or your benzpyrene hydroxylase. So, in a way, effective ang katong immunosecretory function sa small intestine in a way because it protects it from carcinogens through the action of these substances. And then lastly, the small bowel or the small intestine contains efficient apoptotic mechanisms that allow them to eliminate clones that contain genetic mutations. So this is just a table that I copied from the book. So you have there the features of the small intestinal malignancy. So including the sites wherein they are commonly seen. So for the adenocarcinoma, the cell of origin is the epithelial cells, and as I mentioned earlier, they comprise about 35 to 50% of the malignancies that we see, and the predominant site would be the duodenum. While the ileum is one of the common sites, no, for intestinal malignancies. We have the carcinoid type and the lymphoma that are frequently found within this area. And then we also have the GIST or the gastrointestinal stromal tumors that originate from the interstitial cell of Cajal, which is considered as the intestinal pacemaker. So the frequency is around 10 to 15%. So although the GISTs are commonly found within the stomach, there are also incidences or cases wherein we can find it in the small intestine as well. So for the clinical presentation, most intestinal neoplasms are asymptomatic. So until they become large. So when they happen to be at larger sizes, the signs and symptoms of these tumors may mimic signs and symptoms of obstruction. So sometimes the symptoms may be non-specific. So they can experience abdominal pain, weight loss, nausea, vomiting, occult bleeding, and of course, as I mentioned, signs and symptoms of obstruction with possible perforation. Now let's go to the types of tumors that we commonly encounter, and one of it is the carcinoid or the neuroendocrine tumors. So this is the most common malignancy located in the small bowel. So if you notice, I highlighted the word malignancy. Okay, if we're talking about benign tumors, then the most common would be adenomas. But for malignancies, it is the neuroendocrine or the carcinoid tumors. 45% of them will occur in the small intestine, and they are often associated with other types of cancers. Later on, we will discuss them. So majority of the duodenal carcinoids will usually produce gastrin and somatostatin. So your carcinoid tumors in the small intestine can be part of a syndrome, no, commonly known as the carcinoid syndrome. So these patients usually manifest with flushing, abdominal pain, diarrhea, bronchoconstriction, hypotension, and tachycardia. And sometimes they may have the complication of having carcinoid heart disease. 30% of the time they will be multicentric, meaning they can be in different areas of the small intestine, and they can coexist with other carcinomas such as colon, breast, and gastric cancer. There is a 50% of the time there are intestinal carcinoids located in the appendix. Remember, later on, I know that in anatomy you have seen that the appendix is quite in close connection, no, to the location of the small intestine, particularly the terminal ileum. And for the carcinoid tumors, 25% of them are usually located distal 2 feet of the ileum. How do we diagnose patients with carcinoid tumors? So one way of diagnosing is to measure the 5-hydroxyindole acetic acid levels, no, in a 24-hour urine sample by serum analysis or by serum analysis of chromogranin A. So both of these tests, although they are highly specific, no, but they have a low sensitivity in diagnosing patients with carcinoid tumors. That's why it's very important to still do an abdominal CT scan as an adjunct to visualize the location of the tumor. Upper GI with small bowel follow-through examinations have reported sensitivities around 30 to 44% respectively. Also, MRI and somatostatin receptor scintigraphy or the ocreatide scan can also help, no? For cases wherein there is a consideration of a possible metastasis to other organs, and we can also do a positron emission tomography scan. Now, for the treatment for carcinoid tumors, surgery would still remain to be the only potentially curative therapy. We do en bloc resection of the affected area with extensive lymphadenectomy and wide resection of the mesentery. So carcinoid tumors have a higher chance of recurrence if we don't remove the lymph nodes affected as well. So we have to do proper removal by doing extensive lymphadenectomy as we do the segmental resection as well. Next will be the lymphomas. So lymphomas are usually commonly, di ba, ang lymphomas have a tendency to occur within the central areas, no? So you have there the tonsils, the neck nodes, no? Since the small intestine contains a lot of lymph nodes, no, or the pairs found in the Peyer's patches, they also have a high propensity for the development of these type of neoplasm or malignancy. So the primary small intestinal lymphomas, these are usually located in the ileum, and the most common presentation will be patients coming in for partial small bowel obstruction. Fortunately, only 10% of these patients have bowel perforation. For lymphoma in general, we know for a fact that the treatment is usually medical, no? So can anyone remember the regimen for of chemotherapy that we give for lymphoma? Actually, it's there in the slide, no? It's a CHOP regimen. So ang pangutana na unsa man ang CHOP, doc? What is C, what is H, what is O, what is P? So that will be a part of your assignment. So for localized small intestinal lymphoma, segmental resection can be done involving the intestine together with the adjacent mesentery is removed. Not unless if the patient presents with signs and symptoms of intractability, hemorrhage, obstruction, and perforation, shall we do surgery for these cases? Because most of the time, it is responsive to chemotherapy. So if, for example, the patient happens to have a disseminated type of disease, meaning there is a large segment or section of the small bowel, including the other adjacent structures that are involved, then we can just do chemotherapy for these patients rather than doing a surgical resection. Next type would be the adenocarcinomas. So we have already discussed carcinoid tumors, lymphoma, then followed by the adenocarcinomas. These are the second most common malignancy found within the small intestine. And it occurs most often in the duodenum. Remember that your adenomas happen within the duodenum as well. So the chances for malignant transformation is also higher in that area. Signs and symptoms usually are non-specific. That's why it may lead to significant delays in diagnosis. But however, if they are enlarged or large in sizes, patient will usually manifest with with obstructive symptoms. Most of the time, 50% of patients are found to have advanced disease, either a stage 4 or a stage 3 disease, and they have a higher chance for distant metastasis at 24%. 30% of them will always have to involve lymph nodes. That's why if we do resection, we still have to do adequate lymphadenectomy with removal of the mesentery affected. For the diagnostics and treatment, no, it depends upon the location of the adenocarcinoma. If it happens to be located in the duodenum, so we have to check, no, whether this is located in the first, second, or third portion of the duodenum. For periampillary lesions, meaning those that are located within the second portion of the duodenum, it can be diagnosed through doing an EGD, an endoscopic ultrasound, or even an MRCP, as well as a video capsule endoscopy and a barium swallow. Primary treatment would involve the removal of the tumor through surgical resection. So for cases who happen to have tumors located in the duodenum that especially in the second portion, no, there might be a need to do a more radical surgery, which is a Whipple's procedure, in order to remove the tumor, entire tumor, no. So the patient might need a more, what you call this, radical type of procedure. But for those tumors that are located within the other portions of the intestine that is not adherent to any other organ, no, then we can do just a wide excision, surgical resection rather, with a wide excision of the corresponding mesentery to achieve regional lymphadenectomy. However, no, for locally advanced or metastatic diseases wherein there is already disseminated disease with probably involvement or metastasis to the lungs, no, palliative intestinal resection can be done without the removal of the lymph nodes, or an intestinal bypass is performed. So when we say intestinal bypass, no, we just try to connect the proximal portion of the obstructed area to another portion, free portion of the intestine, to allow free flow of food and nutrients, fluid and gases into the distal portion of the small intestine. Okay. And unfortunately, for this type of tumors or malignancy, chemotherapy has no proven efficacy in the adjuvant, meaning post-operative or palliative treatment. So this is quite a aggressive type of cancer, and usually patients die secondary to the metastasis or secondary to the consequence, no, like secondary to the obstruction, sepsis secondary to the obstruction if you cannot address it. Okay. So this is just a typical picture, radiograph, no, of a patient, no, who had barium series of the intestine. So what do you call this type of deformity or defect? How do you describe this one? Huh?
Is it the
What's that?
apple?
Yes, so this is the apple core deformity. So if you notice, no, meron siya gipaak sa iskakilid, and then it's the core, no, of the apple that is present, no, in the center. So this would indicate what? Possible intraluminal mass, no, that is causing the obstruction. Okay. So in the absence of a CT scan and the patient is stable, no, another imaging option that you can do would be a barium series, no, radiographic series with contrast such as this one. Okay. So I think we'll tackle on the first few slides of intestinal fistulas, and then maybe we can end 10 minutes before 4 so that you can rest. So the next topic that we will discuss would be about intestinal fistulas. So fistulas are in general defined as an abnormal communication between two epithelialized surfaces, or is a communication that occurs between two parts of the GI tract or the adjacent organ or the GI tract with the skin. Okay, so for example, you have a communication between the skin and the rectum. So how do you call that? That would be a cutaneous fistula. So you have a communication between the two. So what about for if you have a communication between the colon and the bladder, how do you address that? So that will be a colovesical fistula. So it usually has a connection between two adjacent organs or two epithelialized surface. For a fistula to happen, there should be complete epithelialization or mostly lined by simple granulation tissue. So there are two types of fistulas. You have your internal fistula and the external fistulas. So your internal fistula, example of that would be your enterocolonic or your colovesicular fistula. So this is where the two parts of the GI tract or adjacent organ forms an abnormal communication. While an external fistula involves the skin or the another external surface epithelium. So an enterocutaneous fistula, which is connection between the skin and that of a small bowel, is considered an external type of fistula. So this is how a typical patient with fistula would look like, no? So you have their patient post-operative patient, no, with communication of the skin to a GI tract, no. For this particular patient can unfortunately, when we tried to clean the wound, no, there was already fecal material coming out from the abdominal wound. So thereby we concluded that this patient might have fistula formation already. So the other pictures will just show to you the schematic diagram of how these fistulas would look like internally. So there would be a communication. Like for this particular patient, there would be a communication from the colon towards the skin. Okay. So there are aside from the type, based on the location, no. So we also have a type based on the volume of output, no. So we classify fistulas based on the volume of output as low output fistulas, which drains less than 200 ml of fluid per day, and the high output fistulas, which drain more than 500 ml of fluid per day. So if you happen to have a patient with fistula, it's very important for you to quantify the volume of fluid that is coming out from the fistula in order to determine whether it is a low output type or high output type. For some literature, there is a third type, which is the intermediate type, no. But for the uniformity of the data, we will just follow what is written in short. So if it is less than 200, then it is a low output fistula. If it is more than 500, then it is a high output type of fistula. Now, majority of enterocutaneous fistula unfortunately represent iatrogenic complications. So it's either intraoperatively, there were some, when we say iatrogenic, baka nang wala bitaw tuyo nga mga complications like intraoperatively na ay nanik nga portion sa small intestine, or there was a technical problem, no, wherein unfortunately natahi og apil ang small intestine, thus causing a violation in the mucosa. So most fistula, regardless of etiology and location, they have the potential to close spontaneously so long as the condition of the fistula is conducive for healing. Now, I listed there in the slides the different factors that can cause that can inhibit, meaning this can prevent spontaneous closure of fistulas. So if, for example, you have these factors within your patient, no, and the patient is having an enterocutaneous type of fistula, then there is a high chance that the fistula will not close. So you have to make sure that these factors are not present in order for the fistula to heal. So this is a table that I borrowed from the book. So you have there the factors that negatively impact enteric fistula closure. It's the same as the first slide, but this one is in tabulated form. So this one is another table that gives you an idea as to the factors that can cause spontaneous closure. So in the book, you will notice that there are factors that are contributory to the healing of the fistulas, and we have a mnemonic for that known as friend, no? So the friend factor, so FRIEND. So F stands for foreign body, R is for radiation, I is inflammation, I, infection, I, inflammatory bowel disease. Then you have E for epithelialization of the fistula tract, and neoplasm, and D is distal obstruction. So if you happen to have these factors, then there is a chance that there would be no spontaneous closure of the fistula. So the fistula will not heal, no, despite all your efforts. So the clinical presentation of fistulas, no, they can, as I said, no, 80% they are iatrogenic. So usually they become clinically evident between the 5th and the 10th post-operative day. So when you try to dress the wound of the patient, no, initially it's clean, but later on after the 5th day, no, the presence of seroma, no, or meaning fluid, no, within the serous fluid within the wound could possibly lead you to think that there might be a problem inside, no? So usually during the 10th, within the 7th to 10th postoperative day, there might be succus, no? Or if it's a small bowel fistula, there would be bilous fluid coming out already of the wound. If it is colonic or rectal in nature, then there would be already fecaloid contents coming from the wound. The initial signs and symptoms of the patient would be fever, leukocytosis, prolonged ileus, as mentioned earlier. Abscess or infections can cause ileus. You have abdominal tenderness, wound infection, or seroma. So obviously, di ba, makita man na ninyo if there is drainage of enteric material already, di naman na siya normal. If there is pus coming out from an abdominal wound or your post-op wound kana, you might think of, maybe this is just infection. But of course, if ang mugawas sa wound is fecal material na ba, it's already feces coming out, then of course you wouldn't think of infection. Then you would probably think, maybe there is already fistula formation for this one. And mind you, fistulas are often associated with intra-abdominal abscesses. So for the diagnostics, very important to do diagnostics with CT scan of the abdomen with oral contrast, because it's the most useful initial test, no? Like for this particular slide, no, you can see there a communication between the bladder and the colon. So here, no, this tract here, I don't know if you can see it clearly, but from my end, I can see it, no? So there is a tract in between the two structures. So this could be a colovesical fistula based on the imaging findings that we have here in CT scan. If CT scan is not available, another useful diagnostic modality would be a small bowel series or enteroclysis. For fistulogram, we used to do fistulogram before. But right now with the advent of CT scan, CT scan is more useful because we can be able to visualize the structures that are in abnormal communication with, no. But for a fistulogram, this is usually a radiographic examination wherein a contrast is injected, no, into a catheter placed percutaneously to trace the fistula tract. So this just traces the fistula tract, but it doesn't show to you the involved organs that are or the involved organs in the fistula tract formation. Okay, so I think we will end with the diagnosis, and maybe we can start on Wednesday with the treatment of the fistulas. So I will give it as an assignment for you in terms of how do we treat fistulas and what's the stepwise management for intercutaneous fistulas. So next meeting, maybe we can start with a 10-item quiz, no? About the previous topics that we have discussed, including the assignment about the treatment of your fistulas, no? In order to break the ice on Wednesday before we do our lecture proper. So for the coverage for Wednesday's lecture, it will be a continuation of the fistulas and intestinal fistulas. We will discuss also about short bowel syndrome, tuberculosis enteritis, and then as well as the intra-abdominal infections, involving mostly on primary peritonitis and secondary peritonitis. Do you have any questions? Wala ra, nasabtan ra ninyo? Were you able to understand? Okay. So relatively simple ra ang topic sa small bowel, no? But katong mga reading assignments na gipang-assign ako sa inyo, just also read on it. Mga short paragraphs ra gyud siya. So wala na ko siya gi-appeal kay you take time ang good. So I give it to you as an assignment, but these are still included in your examination. Okay? No questions? No takers for the questions?
Excuse me, Doc.
Yes.
I have a question on ileus, cardiac ileus ba, Doc? Diba? You said earlier na it's important to ask post-op patients if kanang flatulence ba, Doc, if nakautot na sila. So can we give drugs that can shorten the period of post-op ileus, or we just have to wait naturally for it to occur?
Okay. There are some who advocate for the use of kanabitong drugs, no? Claire, nakabasa ka sa mga drugs nga pwede na to mahatag?
The pharma, Doc, akong na-remember is alvimopan.
So, dili kay siya ko mo.
And also, I remember, Doc, na ang tramadol ba, dili ta makahatagan na sa post-op pain management ba sa patient?
Yes, it can also cause ileus, no? That's why itong akong gingon na there are some analgesics such as mu receptor antagonists that we give, no, for patients with ileus. But to your regards sa imong question, there are studies that have shown, no, nga na ay effect I don't know, maybe you can add this as your assignment, the role of metoclopramide and erythromycin for postoperative ileus. But ang ilang study was not really that popular, no, kay mura bitag ang outcomes sa patients nila dili jud siya ingana ka significant in terms of decreasing ileus as compared to early ambulation, early feeding or sham feeding, no. They found out that these drugs do not really significantly decrease on the amount of hospital days that the patient will have, no, once they have ileus. But for patients with ileus, it is very important para nako no or na, yeah, in most of the time for the other surgeons as well na we wait for it naturally to resolve, no. We may help in terms of NGT decompression, for example, if distended yun ang tiyan sa patient, but sa akong experience, kasagaran mo resolve yun na siya on its own. So that's why we always ask the patient kung makalingkod, makalakaw, lakaw-lakaw na kay aron makautot. O aron makalibang ka, kay walking, movement, ambulation can stimulate peristalsis as well. So kana sham feeding also is important, or we give early feeding, no, either through ice chips, water, sips of water, so to stimulate the motility of the small intestine or the bowels, no, for at that. So I think those are the most important measures that we can shorten ileus. Although there are studies that have shown that some drugs such as metoclopramide and erythromycin can help in resolving ileus, but the findings that they have among their studies were not that significant. Dili siya nga naka-significantly sana maka-contribute, no, as compared to the previously mentioned measures nga kana early ambulation, early feeding. So kana siya. I hope I answered your question.
Okay, thank you.
Okay, any other questions? Wala na? Okay, so if there are no other questions, so I'll see you on Wednesday. So please prepare for the short quiz on Wednesday. So thank you very much, everyone. So I hope you've learned something new today. I'll see you on Wednesday.
Good afternoon, Doc.
Yes.
Where me mag-take sa quiz, Doc, this Wednesday?
Sige lang, I'll just give instructions on how to take the quiz on Wednesday morning. We won't use the Google form.
Okay, Doc. Thank you.
Okay, thank you, everyone.
Thank you, Doc.
Thank you, Doc.
Thank you.
Thank you, Doc.
You know.
Much, Doc.
Doc.